This should be live now, and it should be working.
Okay, no, yes. Yes, it
Yes,
says you're now live in the group.
yes, it is working. Fantastic.
Yay! Awesome,
Yay,
awesome.
finally. All right,
Bye.
I can see you. I'll call you soon. Bye.
Okay,
Okay,
bye.
bye. All right, guys, welcome. Sorry about that, a few technical errors, but I think we finally figured out how to do this and not have too many problems going in the future. Trish, can you just type something up to say that you are definitely hearing me? And I'll just turn the volume up to make sure you can do that. Um, yes, it is working. Hi, Julie. How are you? Um, welcome. I'm just in my study at home, so I apologize if my two little rugrats come running around and making a bit of noise. But I think we should be all right. I have asked them to behave a little bit while we do this. Um, so, welcome to this evening's Facebook Live. The topic for tonight is going to be breast implant safety, and it's a very broad topic, but we're going to talk about a few things that have been raised, certainly by my patients in the last week, and certainly following the Four Corners program that was on um, Monday week, I think it was now. Um, Hi, Tanya. G'day, Isabella. So, guys, if you've got any specific questions, please type them up here, and I will do my best to answer them for you. I also will look at a list of questions that Trish has forwarded to me from people that might everyone sort of has an interest in these questions, and maybe I can start by answering some of these questions for you. So, the first question I have is can any breast screening clinic or practitioner do a proper breast check with patients with implants, or should it be done by a specialist plastic surgeon or other specialist? Look, that's a very interesting question. It's actually a very good question. Um, the answer to that is actually split into two components. The answer to that is it boils down to, is the person who is examining you for breast cancer, or are they examining you for a problem that is physically wrong with your implant? If your doctor is examining you for breast cancer, provided that the doctor is competent, does not need to be a specialist, most general practitioners will do this. They can certainly examine the breast, they can certainly examine a breast, whether it's had an implant or not, and see if there are any lumps around, and also then send you through to appropriate screening should they feel that there is something there that needs to be looked at. Now, as part of their examination, they may feel the implant, or they may feel aspects of the implant that seem unusual. And if, I guess, your specialist or your general practitioner in particular is clued in, then they may think that there's something there and may refer that on, particularly as part of the investigation. However, if you are referring specifically to a doctor who is going to examine you specifically for your breast implant itself, and to try and assess whether there is a physical problem with your breast implant, then you should go to a specialist plastic surgeon, or you should go to the doctor that put the implant in you in the first place. Now, if that is not a specialist plastic surgeon, there are a lot of ladies who have had breast cancer, for example, who have had a qualified specialist general surgeon who would put the implant in for breast cancer. They would certainly be able to assess that as well. However, from an aesthetic point of view, from a cosmetic point of view, the person that's best suited to assess your breast and be able to assess it as to whether there is a aesthetic problem, something such as a capsular contracture, potentially a rupture, and in today's environment, I guess you're concerned about ALCL, anaplastic large cell lymphoma, then in that situation, I do think you are better off seeing a specialist plastic surgeon to assess that, because that's what we do all the time, and we have a pretty good idea of what an implant following capsular contracture looks like. And then, of course, you're in the right hands to deal with that should something be needed going forwards. Hope that helps. Now, so feel free to ask questions. I'm just looking at some comments here and seeing what questions are coming through, and we will go from there. Okay. Um, the next question has come through in terms of what is the difference between screening a patient who has breast implants and screening a patient who doesn't have breast implants. Again, this question is a follow-up, I guess, from the first component, and that is, are you screening a patient for problems with a breast implant, or are you just doing a breast screen? As I said earlier, a breast screen can be done by your general practitioner. A breast screen can be done by your general surgeon who has a breast oncological experience, if that's who's been looking after you from a breast cancer point of view. Cosmetic or aesthetic surgery, of course, the assessment would be or should be done by a specialist plastic surgeon. Now, the differences are very clearly one patient has a implant and one patient doesn't. Now, if you have had a mammogram, or if you are someone who is in the right age group for a mammogram, it doesn't matter whether you have a breast implant in or not, as to whether you can have a mammogram or not, as to whether you can have breast screening or not. What does happen is that the actual specific views that are required, or the way that they actually take the imaging, changes. For some situations, that may mean an ultrasound on top of your mammogram, but they do what's called an Eckland's view, where the actual implant is pushed sort of forwards and before the breast is compressed. So it actually looks at the actual breast itself with the implant in tow, rather than your stock standard views where you're just compressing the breast itself. Now, the next question to this almost always is, well, if I'm having a mammogram and they're going to compress the breast implant, what are the chances of the implant breaking or bursting? I can tell you, I've driven my car on an implant, and I'll probably put that on my Instagram one of these days to show you. People have ridden bikes on their breast implants. These are very robust, prosthesis, and if you're going to have a mammogram, it is almost virtually unheard of that a mammogram will cause a rupture or a problem with your breast implant. So yeah, they both will. If you're having a mammogram as a screening process, then yeah, that's going to be the same sensation, maybe a little bit more tender than a standard mammogram. But if you're doing a breast implant screen, so you're going to check to see whether the patient has something that concerns you. It's going to compose of two sections, I guess. And that's what I do with my patients. The first is a clinical examination. So that's painless. That's to check and see what the implant looks like, what the patient looks like, whether there's any changes in the shape of the implant, whether you have any evidence of capsular contracture. These are the things that we can see physically. Also, whether there's any physical change in shape or size, or whether there's any fluid accumulating on one side or the other, which is often, normal, but can also be a sign of anaplastic large cell lymphoma, something we need to be concerned about a little bit more these days than in the past. So first is a complete physical examination by a specialized plastic surgeon, and in that situation, you might pick up on things. But if there are things there that concern you or that concern the surgeon, if there's something that is brought up, then the next test is going to be either an ultrasound or an MRI, depending on what the doctor suspects. And an ultrasound is painless, and an MRI is painless. So a proper screening of a breast for potential issues or problems following breast implant surgery should be painless or relatively painless. Tanya, you've asked a question: how often would you suggest breast screening with implants if a patient has a family history of breast cancer? Yes, look, that doesn't change. Irrespective of whether you have implants or whether you do not have implants. The implants in that situation is just purely a red herring, right? So if you have no history of breast cancer, the recommendation is 45. You have to be 45 or over to have a mammogram. If you have a history of breast cancer, or if you have a high potential risk, whether that's genetic, etc., then you would do your mammograms or investigation starting 10 years earlier. And in that situation, it may be a mammogram, or as you are younger, you have more glandular tissue rather than fat, you may have to get an adjunct screening process like an ultrasound at the same time. So having an implant doesn't change when you have your breast cancer screening. Having an implant doesn't change whether you need to do it quicker or later, depending on whether you've got a family history of breast cancer. That's fixed. All that changes is maybe how they do it, or maybe what they might need to do on top of the standard screening, but that won't change. So 45 and 10 years younger if you're at high risk, irrespective of whether you've got an implant or not. Hope that helps. Um, Going forward, still on the breast cancer topic. So, hi Sharon, how are you? Um, there's another topic here. Is it harder to detect breast cancer in patients with implants? Uh, Actually, there are some papers to say the opposite. It's actually sometimes easier to detect a breast cancer or a lump in a patient with implants. Now, if you have a small or reasonably small breast, it might, you might be able to palpate a small breast cancer in that. I guess it's all relative to size. But if you have a breast implant and it's pushing that tissue forwards and making it more accessible, if you like, then there is some suggestion that in that circumstance, feeling that breast tissue, because it's been brought forward and easier to actually sort of palpate, might increase the ability to detect someone with breast cancer. So definitely not harder, just different, particularly with the mammographic investigations that one would need to do. The other questions we've sort of been talking about, and I guess one of the things that has concerned patients a lot, particularly since the Four Corners program, has been who is doing your breast augmentation surgery, what are the follow-ups, and how do you know if you've been operated on by someone who is qualified to do the operating, and what happens if you're not in that situation, or if you've seen someone who you thought was qualified but it turns out that they're not, and you're concerned about the implants that you have now been placed into you. Look, I think that's a very genuine concern that's out there. I'm certainly not going to sit here and say, well, you should just always have your breast augmentation surgery by a plastic surgeon. As a plastic surgeon, there are significant reasons why, not just myself, but my colleagues feel that breast augmentation surgery for cosmetic reasons should be done by specialist plastic surgeons. That's not to say that there are cosmetic surgeons out there who, by virtue of operating for a multiple years and developing experience, might be able to put an implant in reasonably well. I guess that's the basis for a lot of patients who come through, or who have gone through this process, saying, well, you know, Dr. X or Dr. Y is not a plastic surgeon, but they did put breast implants in me and they look fine and I'm fine. And, for a reasonable proportion of patients, if they've been to someone adequately trained, then that will be the outcome. The problem here lies in that term, adequately trained, is very loosely interpreted. The only body in Australia the only body in Australia that is approved by APRA and approved by the Australian Medical Council to train doctors in cosmetic plastic surgical procedures is the Royal Australasian College of Surgeons, and therefore doctors who are trained in plastic surgery, specialist plastic surgeons. What are the benefits of that? The benefits are multiple years of training, usually 12 to 15 before you do your first breast augmentation on your own. While you may have done a lot with supervision with your consultant, until you become a consultant yourself, which is on average 12 to 15, sometimes even longer, you tend not to do any cosmetic breast augmentations without supervision. So there's a lot of training that goes into this process before you actually get to start doing these operations. As opposed to doctors who go and do a course, who might have spent 48 hours with another doctor, and at the end of that will call themselves a cosmetic surgeon or a doctor who is trained in breast augmentation surgery. And if that doctor then goes on to perform these surgeries, you're comparing someone who's got 12, 15, 20 years of experience on one side versus a doctor who's got 48 hours, maybe a couple of weeks. Now, if they've done that, they quite often will charge at a different rate. Quite often, you might end up being operated on without general anesthetic. Quite often, and as you saw in the 60 minutes, in the Four Corners program, you might be done in a operating theater right next to a Chinese restaurant. Um, you might not have any anesthetic. You might have a bit of local anesthetic placed into your breasts, where you can feel the entire procedure. In fact, it can be extremely painful, as some of these patients complained about. There would be questions about infection and sterility. And then if you do have problems, and if you do have issues, then I guess the other question that you need to ask yourself is, am I having surgery by a doctor, a surgeon, who can deal with these problems? None of these operations are without their problems. All operations carry a risk. And so I can't sit here as a plastic surgeon and say, look, come to me as a plastic surgeon and you'll never have a problem. That's not ever going to be the case. What I can say is, look, come to me as a plastic surgeon, or come to my colleagues who are qualified specialist plastic surgeons. And if you have an operation with them, and if you have a problem, then you're with somebody who is adequately trained to identify the problem, adequately trained to correct the problem, and correct the problem in a location, in a controlled environment that is in your best interest. And that will usually be in a proper private hospital that is an accredited private hospital, and not just sort of, fly by night day surgeries around the place. And it will be done more than likely, depending on what it is, but quite likely under a general anesthetic, looking out for your best interests. So that's very, very important from my point of view, and I think from every plastic surgeon's point of view. Now, the question I've been asked is, what about a breast surgeon, oncoplastic surgeon? Yeah, like, I could be very cynical and say everybody loves the term plastic surgeon, and suddenly, there's the facial plastic surgeon, there's the oculoplastic surgeon, there's the oncoplastic surgeon, and then there's me, and I'm just the specialist plastic surgeon. And it muddies the waters, and it makes you think, which doctor can I go to? When we train, with the Royal Australasian College of Surgeons, we are all trained in our own individual specialties. For example, if you make it an analogy from a car point of view, some doctors are trained in fixing tires and properly trained in fixing tires. Some doctors are trained in fixing headlights. Some doctors are trained in changing the upholstery in the car. Now, they're all specialists in these areas. Now, that all those doctors would have been trained by the Royal Australasian College of Surgeons. So you might have an orthopedic surgeon, you might have a general surgeon, you might have a plastic surgeon, you might have you might have an ear, nose, and throat surgeon. Now, that by definition says that an ear, nose, and throat surgeon operates on the ear, nose, and throat, and that surrounding area. An orthopedic surgeon is a doctor that operates in the orthopedic bone area. A plastic surgeon has the skills to treat plastic surgical related issues, whether that be hand, soft tissue, cosmetic, whatever that might be. Now, all of these surgeons perform procedures that have some level of overlap or can have some level of overlap. As a plastic surgeon, I perform hand surgery. I, an orthopedic surgeon can specialize in hand surgery, and I work very well with orthopedic surgeons who perform hand surgery. Ear, nose, and throat surgeons do perform rhinoplasties in the context of trauma or in the context of significant congenital abnormalities. Now, the procedures and techniques that they utilize are very similar, if not the same, to what I would do as a plastic surgeon if I am doing a cosmetic rhinoplasty, as opposed to a trauma rhinoplasty, which is a different operation for the reason for it, but the same operation technique wise. So, a variety of techniques are called plastic surgery. When you have someone who is, for example, an oncoplastic surgeon, by definition, they are usually a doctor who has been trained by the College of Surgeons, so they've been trained by the right group to work on the right car. But by definition, they've trained far more to work on the cancer side of things. So they're supposed to be working, or they're trained to work on cancer, breast cancer, and reconstruction of a breast using techniques that plastic surgeons use. Now, some of these doctors have taken that one step forwards, and not only do they then use it for cancer reconstruction, which is what oncoplastic means, but then they go on to start using it for cosmetic uses. And because there is no regulation, because there is nothing that says you need to operate within your scope of practice, there is a large group of doctors, or not, sorry, that's not right. There is a group of doctors who perform plastic surgical or procedures that are deemed to have plastic surgical techniques in their own areas of practice. That's a long-winded way of saying that it's a bit of a gray area. And the reality is that some of these doctors can perform the same operations that a plastic surgeon does, but they do not necessarily, or they may not necessarily have been through the eye, the experience, the training to do that operation from a cosmetic approach, and they may approach it slightly differently. If you have breast cancer, if you have a breast implant as a result of breast cancer, an oncoplastic breast surgeon is someone that we would work with. Probably no need to call them an oncoplastic surgeon. They're an oncological surgeon or a general surgeon specialized in breast cancer. That's what it realistically means. A oculoplastic surgeon is actually an ophthalmologist, I gotta pronounce it right, an eye doctor who does procedures that are related to or are in for the patient a plastic surgical nature. That doesn't make them a plastic surgeon. It makes them an eye doctor performing plastic surgical procedure. A facial plastic surgeon is not a plastic surgeon. A facial plastic surgeon is an ear, nose, and throat doctor performing procedures that would normally be performed by a properly trained plastic surgeon. So as you can see, there's a bit of overlap there, and that creates a gray area. And even explaining this, you can see how it can get confusing. So for the general public and for someone doing their research out there, it's even more confusing. The simplest way to decide whether if you're having plastic surgery, whether the surgeon that you're being operated on is a proper plastic surgeon, is to speak to the Australian Society of Plastic Surgeons or the Australian Society of Aesthetic Plastic Surgeons and see if that surgeon is listed there. If that surgeon is listed as an Australian Society of Plastic Surgeons surgeon, then you can be confident that that doctor is actually a proper plastic surgeon trained in doing the operation that you're looking for. Sorry, that's a long answer, but hopefully that helps it. It's a subject that's very passionate. It's very close to my soul, and I'm very passionate about it, as are the vast majority of plastic surgeons that are out there, because it is something that we face on a daily basis, and it is something that we think is very important to tell the patient the difference between these things. Trish has another question. What's the breast screen involved? So I've sort of mentioned that to you, but in terms of mentioned that a little bit earlier. If you're referring to breast cancer, then breast cancer screening is an examination followed by an appropriate investigation, whether that be a mammogram, an ultrasound, or an MRI. Screening for problems with the breast implant is both a clinical examination and history, followed by an appropriate investigation depending on what you find. Right, so oncoplastic surgeon, breast surgeon, again, there are there's two ways of looking at this. So there is a question specifically about what about a doctor who calls himself a breast surgeon? You've got to ask yourself, more importantly, a breast surgeon who has an FRACS and has an additional 2 years breast. I trained as a general surgeon, FRACS, in general surgery before I became a plastic surgeon. If I felt that I could do all the same operations that a plastic surgeon can do, I would have stayed in FRACS and not put in an extra 10, 15 years of my life to be able to do the operations that I now perform as a plastic surgeon. The College of Surgeons, Royal Australasian College of Surgeons, if you are trained under them, you will be trained as a general surgeon, an orthopedic surgeon, ENT, plastics, as I mentioned, and there's a few others. Now, when you do that, one of the areas, so the first and most important thing to take away from there is that a properly trained surgeon, doesn't matter in which area they're going to practice, but a properly trained surgeon will have FRACS, Fellowship of the Royal Australasian College of Surgeons. There's other titles that are very similar and very deceptive that are out there, but a properly trained surgeon for whatever they're doing. If you need to take your family or take yourself to see a heart surgeon, a cardiac surgeon, if you need to see an obstetrician, if you need to see someone because you've broken a bone, the right surgeon for you will carry the title FRACS, Fellowship of the Royal Australasian College of Surgeons. Now, one of those branches is general surgery. And when you train as a general surgeon, by definition, you are training in general surgery. Now, that will be upper GI, so hernias and gallbladders and liver surgery. There will be other sort of aspects from the thyroid, for example, that you would be involved in. And one aspect of your training will be breast surgery. But most important to note here is that the breast surgery that you will be trained in will be breast surgery for cancer, will be breast surgery to detect cancer, to remove the breast for breast cancer, and to some degree, depending on which state and where you've trained and who's trained you, how you're going to reconstruct that. In some locations, the breast surgeon's job is to remove the cancer, and then the plastic surgeon comes in and reconstructs the breast, while in some regions, the breast surgeon will remove the cancer, and for the simpler, and I use the term simpler because they're not a free flap, for some of the more simple reconstructions using an implant, the breast surgeon may reconstruct the breast using breast implants. So they'll develop a technique and they'll get used to that. But their primary training has been in breast cancer surgery. When they finish, all doctors, including plastic surgeons, almost always will go for fellowships. I have a particular interest in burns, for example, so I went and actually did fellowships in burn surgery. Now, other plastic surgeons have an interest in reconstruction of the lower limb. They'll go and do something in reconstruction of the lower limb. General surgeons have that opportunity as well. And so most general surgeons, a general surgeon who has an interest in breast surgery, more than likely will go and have a 1 to 2 year fellowship in breast surgery. The vast majority of this training, depending on where they go, is still going to be breast surgery, cancer-related breast surgery. They're not going to go and suddenly start doing 2 years of purely cosmetic breast augmentation surgery. that tends not to happen. It does happen occasionally. I'm not going to say it doesn't happen, but the vast majority of places where they go and train will be a combination of cancer, cancer reconstruction, cancer removal, and occasionally cosmetic components. Once they've done that, they come back. They usually will set themselves up as breast general surgical doctors, having a special interest in breast surgery, particularly breast cancer. Occasionally, there will be a doctor who's got a little bit more cosmetic experience, but that's not the norm. So if you've got a general surgeon who has breast surgical specialty of interest, you need to ask them which area of interest do they have in their breast surgery? Is that cosmetic breast surgery? And specifically, what is the cosmetic breast surgical training that they have done? Because, like a plastic surgeon who spends their time doing breast cancer reconstruction and cosmetic surgery, you need to be able to have that same confidence in a general surgeon performing that. The vast majority of general surgeons that I know do not perform breast augmentations for cosmetic reasons. They're busy and they certainly have a great practice looking after ladies with breast cancer, and I work with a lot of these surgeons. They don't go down the path of breast augmentation or breast cosmetic procedures. Their specialty has trained them in oncological procedures. Some do, and you need to make that decision. But at the end of the day, there's still a fellowship of the Royal Australasian College of Surgeons doctor, but they may not have that same degree of subspecialty training that a plastic surgeon has. Does that hopefully make it a little bit clearer? We've got another question on breast screening. Can breast screening pick up other issues with breast implants such as rupture, leakage, etc.? Sometimes yes, sometimes no. I think that if you do a mammogram and if they're concerned or if there's something visible on a mammogram, the screening doctor may refer you for further investigations, like I mentioned, whether it's an ultrasound or an MRI, and that can usually pick that up. Certainly, an ultrasound and more specifically an MRI is more than likely going to pick up a problem with a rupture or a leak and actually locate that a lot better. But a standard breast screening may on occasion pick that up. And then, should a woman with implants have more regular screenings than those without, and how often should you have them? No. I think that, someone who has breast augmentation surgery needs to be screened for a different reason than someone who has a history or is concerned about breast cancer. They both need to be screened for breast cancer in the appropriate manner, irrespective of whether you've got a breast implant or not. Breast cancer is breast cancer. Breast cancer screening is breast cancer screening. And you would do that at the same rate, at the same timing, at the same sort of intervals that anybody would have. Now, if someone has breast implants in, then now with the concern with anaplastic large cell lymphoma, you might, when you see your doctor, you might be a little bit more concerned. Certainly between years 6 to 8, which is where this, or 6 to 9, this is where the ALCL seems to start to present a little bit more. This might be a time to be checked out and either have an ultrasound or have an ultrasound or a clinical examination if something is concerning you. After approximately 10 years, then for your implant, just like anything else, you want to go in and just get it checked out. Make sure they're okay. Implants are not lifetime devices. They're devices that do have a use-by date, but I usually tell my patients, look, if it ain't broke, don't fix it. But more importantly, get it checked out. So from years 10 onwards, maybe every 2 years or so, you might want to have an MRI scan to check your implants and see if they're okay. And if they're okay, probably not need to do anything about them if everything else is fine. But if you're going to be in the neighborhood, so to speak, if you're having some other surgery on your breast or around that area, and it's 12, 13, 14, 15 years following your implant, it's probably a good idea to have them changed at that point in time. And I think I've mentioned that question that there is a small risk of damage during breast screening, but it is incredibly minimal. It's barely heard of. I think everybody at the moment is particularly concerned about the anaplastic large cell lymphoma risk. I think people are concerned that they have had breast implants done by doctors who are not properly trained. Certainly, doctors who might have done 48 hours of a course and are worried about their breast implants. They're worried that they might not be in the right plane. They're worried that it might not have been put in properly, or they might be, but they're just worried full stop as to, was it done correctly now that I've gone down and had that path. I think the most important thing here is to actually go and speak to your surgeons, or if you can't go and speak to your surgeon, speak to your GP and see if you can be referred to a plastic surgeon to review your implant for you. Certainly in my practice, what I'm offering at the moment, certainly for August and September, we might even extend that, is for women who have had breast augmentations, have had surgery, and are concerned by their implant, and their surgery was by a non-specialist plastic surgeon. Then come on in, we'll have a look at you, we'll do a examination and a clinical examination. We'll send you off to any investigations that might be required to give you an idea and peace of mind if everything is fine. And this will be a complimentary service. There are no hooks, there are no catches to this. This is purely a community service, if you like, that we're going to do for patients who may not otherwise have access to a specialist plastic surgeon to help them make that decision. So there are details on Trisha's website, and there's certainly details on our website and our Instagram page. If you happen to be someone, or if you know someone who is concerned, then please certainly come in. There is no charge for this. We will just do this to give those particular patients who don't have access to plastic surgeons, including your investigations, which will be bulk billed. There will be no charge for this. Now, it is getting a little bit late. Trish, were there any other questions specifically that you'd like for me to answer? I'm just looking at Trish typing away. While Trish is writing that, if anyone has any questions that I might have missed, if anyone has any particular concerns following the Four Corners story, please feel free to get in touch. We're very happy to discuss anything that you might feel. My team or myself are very happy to sort of have a quick chat. Send us an email. This Facebook Live has been designed mainly to allay fears, mainly to make sure that there's no panic or there's no fear out there that you've been operated on by someone and your breasts are going to explode, or you're concerned about that, or every breast is going to get infected. That's not going to happen. But I do understand that, sometimes someone sees a TV show and gets very concerned about what's going on. And if we can do things to help you feel more comfortable about that, if we can have a quick chat to you, even if it's for 5 minutes, to make you realize that it's okay. And if you feel that you can't do that with your surgeon, because they're not a specialist plastic surgeon, I can guarantee you that all specialist plastic surgeons will be very happy to speak to you. But if you feel that the surgeon you went to, for whatever reason, you're not feeling comfortable, give us a text, send us an email, or talk to us through Trish, and I'm sure one of my team will be very happy to have a chat and help you out. We might call it quits from now, and hope everybody has a lovely evening. Good night, everyone.